And I'll go ahead and introduce you. So good morning, everyone. My name is Alissa Guarneri. I'm a pediatric endocrinologist at UPMC Children's Hospital, Pittsburgh, and I'm honored to facilitate this morning's session. This morning, we have Dr. Gajanthan Tatum from Cincinnati Children's, who's going to be speaking with us.
Hi, thanks for having me. I'm John Tatum. I'm a second-year pediatric endocrinology fellow at Cincinnati Children's. I'll be presenting our Fellows Quality Improvement Project that focuses on improving continuity of care in our Fellows Continuity Clinic. Oh, let's see. Can you guys see that? Can you guys see that? Did I change the screen?
I can see it remotely. Okay. I don't know what the folks in Miami are seeing. I see your title slide.
Okay, it's not changing. It's not changing for me. Oh, there we go. Okay. So some background information about our fellowship and our continuity clinic within that fellowship. So we have 12 fellows across 3 years. Each fellow has an average of 2 continuity clinics per month at our main campus. Each clinic is a half day in the afternoon on a Tuesday and Thursday, and a fellow is assigned one of those specific days to have as their continuity clinic day. And across 3 years, fellows see increasing number of patients, but on average, fellows have 5 patients.
Sorry.
Oh, yeah. Like,
Jonathan, you can continue.
Okay, got it. Thanks. On average, across 3 years, like I said, there's 5 fellows, or sorry, there's 5 patients that are scheduled with each fellow. As far as making follow-up appointments, can be done in a couple of different ways. So the nurse or medical assistant with whom the fellow is working can make that for the patient at the request of the fellow, or the fellow may ask the family to call to make an appointment or stop by the front desk on their way out of clinic to make the appointment at a convenient time. So the problem that our project sought to address was this perception that we were losing continuity with patients. They were getting scheduled nurse practitioners or other attendings, or rarely other fellows. And there are a lot of different definitions of continuity, but for our purposes, our definition was a patient that was seen initially by a fellow that was subsequently scheduled with that same fellow. So we did some background investigation and found that our perception of losing continuity was in fact true. We were only actually seeing 38% of patients that we'd seen initially. We were only seeing 38% of them for that subsequent visit. So only had 38% of continuity. So continuity is important in both in medical education and in patient care in general, which is another reason why we wanted to tackle this project. From a medical education standpoint, continuity, it allows the trainee to be involved with a patient and their disease process from the diagnosis. So involved in the initial workup, and then manage that disease process through its twists and turns, and allows the trainee to react to that, through which there is a lot of learning. And then from the clinical standpoint, there's a lot of evidence out there that supports continuity being better for numerous clinical outcomes. So it's associated with lower mortality rates, lower healthcare costs, decreased healthcare utilization, higher patient satisfaction, and lower hemoglobin A1Cs. So our SMART aim of our project was to increase the percentage of patients seen in continuity clinic who were subsequently scheduled with the same fellow from 38% to 60% over about a 4-month period. So our team consisted of fellows, attendings, registered nurses, medical assistants, and then we had a electronic medical record analyst specializing in the scheduling process. So we truly had a multidisciplinary team. As far as the methodology, fellows completed a rapid cycle improvement course to learn the basics of quality improvement. The methodology we specifically used was the methodology outlined by the Institute of Healthcare. So baseline data was collected over 6 weeks. Like I mentioned, that's where we got that 30% continuity number. And then we created a process map and we assessed barriers using a Pareto chart. So based on that process map and Pareto chart, we created a key driver diagram identifying 3 major pitfalls that were getting in the way of fellow continuity. So these key drivers were, first, clear patient-provider communication, informed and educated families, and then clear communication between the healthcare team. And you may notice that these interventions are focused specifically on the time in clinic. So the context and background of that is, at our institution, there had been previous work in type 1 diabetes and congenital hypothyroidism that found that the higher reliability interventions to improve follow-up were focused on that time frame in clinic. So that's why our focus for this project was about within that clinic time frame. So we completed multiple PDSA cycles, each lasting 2 to 6 weeks. So the first intervention was fellows filling out an underused follow-up tab in Epic. So this is a part of the outpatient encounter on Epic where that anyone can view, but specifically it was important that medical assistants, nurses, and the scheduling center is able to view, that allowed us to delineate the time frame of follow-up and with whom the follow-up should be. So essentially it was a backup, if that information slipped through the cracks. And then we placed reminder signs on computers for fellows to fill this out. We placed reminder signs on the exit doors when families were leaving clinic, so that they would be reminded to make an appointment at the front desk, should that be the way that the fellow had set up how the next appointment was going to be scheduled. We also placed reminder signs in exam rooms for families for them to make appointments while they were waiting for the fellow. And then we also instituted huddles with medical assistants and registered nurses as well, depending on who you're working with. And what this entailed was, before clinic, we would run down the list of patients we were seeing and go over which patients we already knew would need follow-up and make those follow-up appointments prior to clinic even starting. So these are examples of our reminder signs. Just something to catch the eye of people. So we were able to improve continuity from 38% to 69% over 4 months using those aforementioned interventions. And then, so we were able to exceed our goals of improvement. And just to kind of put in real world terms of the success that we had was, so after our interventions, 3 to 4 patients out of 5 seen an outpatient visit by a fellow were then scheduled with that same fellow, as opposed to previously only 2 out of 5. So of course, there were some limitations of our study. So the length of time of this intervention, or of our interventions, was fairly short. So I can't comment on the sustainability of this project. And then just by design, we cannot say exactly which interventions had the largest effect or any effect at all. So it's possible that 2 of these interventions may have been necessary to kind of move the needle with continuity, but just by design, we're not able to comment on that. And then there was a fair amount of variability in our data, as you can see by our run chart. So we attributed this one to small sample sizes. So in a given week, about 30 patients were scheduled total, and only about 13 of those needed follow-up on average. And then there was some inconsistency in fellows implementing the interventions over time. So this was a first-year fellow project, so we had a lot of buy-in from first-year fellows. And then moving to the older classes, it was essentially a coin flip of whether they were going to fill out that follow-up tab. So looking into the future, we're excited to continue trying to improve our continuity and sustain improved continuity. So a new intervention we have in place is changing the scheduling template for first years. So right now, first years only have one follow-up slot. So during the second half of their first year, we're going to increase that to 2, which will allow more opportunity for continuity. We're going to kind of systematically implement pre-rounds huddle. So right now we kind of left it very vague of what that entails, but we're going to come up with a script so that we can more precisely measure exactly the effect that could have. And then we plan on just continuing to engage fellows going forward through reminders during fellows meetings that we have monthly or emails. I'm sure we could come up with some more exciting ways to remind fellows that, you know, we can make a difference if we are concentrating on some of these interventions that we've implemented. So yeah, thanks. I'll take any questions.
Thank you so much. Any questions? We have questions? Yes.
Have you considered getting the MAs/RNs to schedule appointments during the visit?
The question is, have you considered scheduling the MAs and RNs? I'm sorry, I didn't catch the last part of that. What was the last part of that question? I'm sorry. During the visit.
Sorry, what was the question? I couldn't hear it.
Have you considered scheduling the follow-up visits from the MAs and RNs during the visit?
So currently for some patients, we do it before. That would be oh, so I think the issue with that would be that sometimes we don't know about follow-up during the visit. So with the patients we do know, we do before, but sometimes we'll need imaging or labs to kind of tell us about the follow-up, at which time, you know, then we'll either tell the families to call or can be in touch with the scheduling center ourselves. So I think having potentially more, you know, more conditions that or disease processes that we just say like, hey, we should just schedule these follow-up appointments would be a good idea.
And these are for endocrine and diabetes patients, is that correct?
Correct.
Are there any plans to look at transitioning of patients who are graduating to current fellows and incoming fellows?
So that was definitely a problem that we had, and within our data, we did notice that there was a fair number of loss of continuity with those fellows. So we ended up excluding those fellows and those patients, especially from our pre-intervention data, just because, you know, we had, for example, last year we had 2 fellows leave, so there was no way that those patients were going to get continuity. But that's something that would be a good idea to focus on in the future, like a systematic way of kind of continuing that care.
Definitely. Any other questions? Okay. All right. Well, thank you very much.
Yeah, thank you for having me.
John, I think we're seeing your epic.
Yeah, thanks. Sorry, I'm trying to not share.
Ignore the PHI.
There.
Oh, I still see your screen.
Oh,
I
still
don't
see.
see you.
Hold on, sorry. How do I not share this? Stop share, sorry, there we go.
Worries.
Our next speaker is Siobhan Tellez from Cincinnati Children's Hospital. Thank you.
Good morning, everybody. So I'm Siobhan Tellez. I am a pediatric nurse practitioner at Cincinnati Children's, and I am presenting on behalf of our research team. So just to give you a little quick context about Cincinnati Children's, we are an academic diabetes center in the greater Cincinnati region, which turns out to be kind of a tri-state coverage of Indiana, Ohio, and Kentucky. We have about 2,200 patients with an average of 200 plus new onset patients per year. We have a very large multidisciplinary team. We have 14 physicians, about 8 nurse practitioners, and then 18 CDCES who are RDs and RNs. And our patient population is 87% white, 10% Black, and then 1% each of Hispanic, Latino, Asian, and other. We've got about 70% privately insured versus 22% with Medicaid coverage. And our site PI is Dr. Sarah Crothers, who is with us in this session today virtually. And our site coordinator is here in the room with us, Dr. Amy Grant. So we got, let me just disclose quickly, we did get financial support for this effort from a Place Outcomes Research Award, which was awarded to us from Cincinnati Children's Hospital. And we would also like to acknowledge that this project was done in partnership with Drea Med Diabetes and with support from the T1D Exchange QI Collaborative. All right, so just to give you a little quick background now, we did get a wonderful review from Dr. Dillabutter's presentation this morning. So it goes without saying, but it's thanks to the incredible T1D Exchange Clinic Registry that we have access to this information, that greater than 80% of youth with type 1 diabetes are still not meeting glycemic targets. So at the start of the study, Cincinnati Children's had a similar imperative to improve our mean hemoglobin A1C, and at the time it was 8.7%. So there are a lot of different ways that we could tackle this, but this project in particular focuses on improving the delivery of care that we provide, particularly with perspective of diabetes technology. So we all know that we're having increasingly sophisticated diabetes technology, which is absolutely amazing, but it does come with its own challenges. So our clinic structure is that we continue to have provider visits every 3 months, which is based on a historical model of getting a fresh A1C about every 3 months and being able to kind of track progress toward glycemic targets. But with all of this technology, we have this wealth of knowledge that is pretty much going untapped. So I would be genuinely curious. This is a quick little screenshot from Dexcom Clarity CGM report. I would be really curious if anyone looks at this particular screen and says, yes, this is really helpful to me. To me, it just looks like a lot of squiggly lines, but it represents how much information we have. The data is complex and every company has their own platform and there are different ways to display the data. And there's so many views. There's daily, there's weekly, there's statistics, there's trends. And for the providers, that's a lot for us to interpret. If we're only seeing them every 3 months and then we're going back and looking at all this historical data, we just simply can't. We have to whittle it down. And then for the families, you've got months and months of data that really goes underutilized. We're looking at probably 44 out of 52 weeks in the year where we're kind of leaving people up to self-interpretation and management. And a lot of families have access to this data, but they also need to have phones and computers so that they can review this data. And they also need to have the knowledge and skills to interpret the data, know what their goals are, and then make meaningful decisions. So with all that said, how do we take all of the data that we have and make it more digestible? If looking for time and range comes as our primary outcome, then I think we're probably missing critical opportunities to support optimal management with all this in between time. So, whoops. Oh my gosh. Okay, so here's where artificial intelligence can step in to help. Now, artificial intelligence can aid in the aggregation and analysis of all of this data, and it can help to generate recommendations for insulin dose adjustments. And I am referring in particular a program called Advisor Pro, which is an FDA cleared program produced by a company called Dreamed. And this program specifically analyzes pump and CGM data to provide recommendations for insulin dose adjustments and also suggestions for behavior modification at the click of a button. And at the time of our study, Dreamed's platform was built into a diabetes data platform that our clinic was already using, which is Gluco. So for our project, we wanted to use AI-guided decision-making as a part of a continuum of care between the home and the clinic. Our central hypothesis was that by redesigning a care model that values and encourages the role of the family who's managing their diabetes 99.9% of the time, we'd be able to improve glycemic outcomes and also enhance the attention that we're paying to psychosocial care. And that care model would be focusing on the use of AI-guided recommendations in between visits. The person at home would upload their diabetes technology, their pump and their CGM using the Gluco platform. Then the Dreamed Advisor Pro platform would analyze that data, generate recommendations for the insulin adjustments and potentially for behavior modification. The recommendations would then be reviewed and possibly modified by the provider and then shared back to the patient and family. And further, we also wanted to explore the feasibility, the acceptability, the efficacy of this enhanced care intervention. So our study had 3 aims. The first was that we wanted to co-design the enhanced care intervention with the patients and families, and then integrate the AI-guided recommendations into both the provider visits and the in-between visits. Next, we wanted to implement the ECI, and we wanted to demonstrate its efficacy, with the primary outcome being the % time in range, and additional outcomes looking at the hemoglobin A1C, glucose management index, and then also their time below range or percentage of time with hypoglycemia. And third, we wanted to examine the acceptability, the appropriateness, and the feasibility of the ECI using validated survey instruments. This was in the form of sequential surveys to both the patient, family, and also to the providers who were using the recommendation software. So our inclusion criteria is in blue and our exclusion criteria is in the pink color. Apologize that the headings are kind of cut off, but we wanted patients to have type 1 diabetes for more than 6 months. The age range was between 7 and 24 years old, and they had to be using a pump and CGM because at the time, Advisor Pro software could only analyze data from users who were wearing a pump and CGM. And their hemoglobin A1C or GMI range was between 7 and 13%. So we had an enrollment period of 6 months, and it was rolling recruitment, and we had a recruitment goal of 104 patients because we wanted to have the power to detect a 5% change in outcomes when we did statistical analysis. All right, so aim 1, co-designing the ECI. So we designed the ECI with the invaluable input from patients and families. And I'd like to say that one of our co-investigators, Dr. Patrick Brady, is not only an incredible provider, and a source of great guidance and support in this effort. But he's also a parent of a child with type 1 diabetes, so it was really special to have his unique contributions to the construction of this ECI and guidance throughout the project. So the design sessions, we had 4 remote sessions with the patients and families, and we really wanted them to help us decide all the critical features of the ECI, such as how often they wanted to hear from us and how they wanted to receive their communication. So when we kind of reached thematic saturation, it was determined that over the course of the 6 months in the study, they wanted to hear from us monthly, but they also wanted to keep their in-person visits. There we go. So they wanted to keep their visits aligned with our clinic standard of every 3 months. That way, their in-person involvement in the study didn't involve additional in-person commitment. And they also wanted multiple modes of communication. So we ultimately decided that we were going to use automated emails in order to remind families to upload their devices. And then we also were going to use a combination of push notifications through the Gluco app and messaging in our electronic medical record once the adjustments were available for review. And this is just a little visual that kind of shows our timeline of the baseline in-person visit, and then each of those monthly intervals, and then the 2 additional in-person follow-up visits. So in order to achieve aim 2, which was looking at the glycemic outcomes, we compared the baseline data with the data at 3 months and 6 months. So we recruited 96 participants in total, which was very close to our goal. And given the fact that enrollment started in March of 2020, we were very proud to have gotten so close to our recruitment goal. We had an 89% retention rate by the end of the study, and 10 total participants withdrew from the study. 4 of them just weren't able to have their in-person visits within the predetermined study window. And then 2 switched to different pumps that weren't compatible with the Advisor Pro software. And then 2 withdrew due to some frustration with tech issues, which I'll get a little bit more into in just a minute. So the time in range is displayed here as a %, and that was our primary outcome. So that's the little gray row there. But when we use general linear mixed models to examine our data at the 3-month and the 6-month visit, there were no differences seen over time, or for the secondary outcomes of hemoglobin A1C, and then the % of time below range or hypoglycemia. So our final aim was to examine the acceptability, appropriateness, and the feasibility of the study. And we really wanted to know this from the perspective of the patients and families, and also of the providers. So we'll start with some of the themes that we were able to highlight from the patient and family feedback. They reported better glycemic management and improved communication. And one participant in particular said that they felt relief from the pressure or anxiety of having to adjust on their own. And that was really nice to see. But despite our best efforts at a smooth experience, we did also identify a theme of challenges with technology. And that ranged from uploading the pump to trying to navigate the interfacing data between Dexcom for the CGM, Gluco for the pump data, and then Dreamed for the recommendations. This didn't end up coming as a surprise to us because over the course of the study, we did encounter a few interruptions to optimal data flow at various levels. And all of those interruptions were generally associated with adjustments to technical communication between the multiple companies, or simply the challenges and frustrations that come with trying to log in and upload to your devices from home. But when we asked, were the recommendations helpful? Over 90% of the respondents said yes. So we used a validated survey instrument in order to collect the feedback that aligned with our last aim. So this large graph that you see is the aggregate results of the surveys at the 6-month visit. So basically at the end of the study. And the light and dark green bars correlate with agreement with the items, such as this intervention seems possible, this feels like a good match, this seems suitable, I welcome the intervention, I like the intervention. Those are some of the items that are on the side there. And then the neutral responses are in gray, and the disagreement responses are in 2 shades of red. So as you can see from the family's perspective, the overwhelming response throughout the study was positive, with very few individuals disagreeing with the acceptability, appropriateness, and feasibility of our ECI. And we were really pleased to see this because this was despite all of the technology challenges that we encountered. So we wanted to also get this from the provider's perspective as well, because of course, they're the ones who are using these recommendations in the context of busy clinic visits. So as you can see here, very similar layout to the chart with agreement in green and then disagreement in red and neutral in gray there. But you can kind of see that there is more of a mixture of responses to using the recommendations in the ECI. Some of the providers felt that the recommendations were too complex. They were getting offered too many adjustments to make at one time, and they wanted adjustments to be a little bit more simplified. Some providers disagreed with the recommendations given, and a lot of times that was because when talking with the family was actually making some adjustments on their own that just didn't really get communicated through the pump data. For example, they might be changing the amount of carbohydrates they're even putting into the pump in the first place because they're trying to mitigate a high or a low. And then from the data perspective, that's not really coming through. And then some of the providers also just commented on the usability. At the time, there was a separate tab to move over in order to access the recommendations. And so they wish that the recommendations were better nested with the rest of the device data, and there weren't extra steps for clicking to try to access the information. All right, so with regards to what we took away from this study, families overall expressed positive feedback and that there was a benefit to getting those monthly adjustments guided by the AI decision support tool. And that supported our hypothesis. Now, the provider feedback was more heterogeneous, with some of the concerns being complexity of adjustments and then suboptimal agreement with the recommendations. And that presents a future opportunity for optimization, especially in the context of the clinic environment. Diabetes device data continues to be a challenge because there continue to be barriers to uploading consistently. And I think this is a hurdle that we're kind of seeing across the board. So again, a great opportunity for learning from others and continuing to optimize this aspect. And it really does speak to the fact that, you know, we're trying to reduce the burden for the families. And we found that when things were manual, we had multiple steps to try to get things uploaded. That was harder for families. And when things were automated and it was cloud uploading and it was very, very simple, then things were a lot easier. And then our glycemic outcomes did not change significantly, but the enthusiasm from the participants that we saw for the ECI and the AI guided tool really does encourage us, and it suggests continued acceptability of the intervention, which means that over a more longitudinal application, we might potentially start to see some glycemic improvements. And as long as we continue to improve the communication between diabetes device platforms and kind of help to mitigate some of those barriers to uploading consistently. So overall, this was a really great start to integrating artificial intelligence as a tool for making diabetes device data more digestible for the families and the providers, and then kind of pushing the needle a little bit further in making that inter-office contact more accessible and a little bit more equitable. So this has been really energizing for us to see the overwhelming enthusiasm for the effort in general, and then also exciting to have identified additional opportunities for growth and development. Thank you so much.
That was really excellent. So just unclear about the design, was it single arm or did you have a control group not getting the AI?
It was single arm. So everybody who was recruited into the study participated on some level with receiving recommendations and then also getting follow-up and visits. And if they didn't, it was simply a product of technology issues rather than a control group.
So were you surprised there was even like some slight increase by 3 months if they're getting monthly reminders to change settings?
I think we were hoping to see a little shift, but because of the technology issues, I think we were not completely surprised that we didn't fully get a chance to assess the actual impact of the AI guided decision support tool at the degree that we were hoping at the beginning of the study, if that makes sense. So we would have liked to, but I think a lot of the barriers that we encountered were a great learning opportunity of like, how do we make it easier to, interface all this technology? And I think that was enough of an interruption that we were kind of like, well, we probably need to study this for a little bit longer.
Do you know what percentage of time when a recommendation was made for them to make the change, they actually did follow what was suggested?
Yeah, that's a really great question. So I have a couple of, let's see here. Yes, definitely. So the question was, do we know what percentage of the time when we made a recommendation were the changes made? It was a little bit hard to track because we relied on the families reporting back to us whether or not they actually made the changes. And with multiple messages going back and forth between provider and family member, you can imagine that there was a little loss of engagement that happened in that process. So we did have, I think, from the patient level, we had 36% of our planned interval reviews completed. So I think that answers your question. And then we had 43% that were not completed for a variety of reasons.
Quick question. Did you do all of these during COVID? You started in March. Do you think that could have interfered in the engagement or the time spent? Because everybody had all the stresses to deal with. Do you think if this wasn't done during COVID time, we would have a better result?
That's a great question. So the question is, do we think that COVID impacted our study from a perspective of engagement? Everybody had other things on their plate. I think probably yes. Even just enrollment in general was challenging because we went from consenting in person to then pivoting and having to come up with digital consent. And then there were a lot of interruptions to follow-up visits that largely had to do with difficulty of access, getting rescheduled if people missed an appointment. And a lot of that was kind of fallout from COVID. So I think there was probably some impact of everything that was happening in 2020, 2021, that not only impacted the engagement in the interval times, but also it affected our follow-up when we did our 3 and 6 month visits. So yes, great question.
Yeah, no, I think the comment about the data not reflecting what families are doing at home is really important. And I think that needs to come in before we make recommendations, because there's what's happening around their home on a regular basis. So for us to be reaching out to their advice first often misses that information. But I'm just curious if you have any data on engagement before the introductions, and whether there may be two groups. Some who had a lot of engagement with technology and some who didn't. And there may be a difference in those, whether in outcomes or in other ways, and those who didn't have upfront engagement before the study.
Yeah, so that's a really great point. So there's kind of two pieces to that. First and foremost, that it's hard. I'm repeating that it's hard to provide recommendations up front because there are a lot of patient and family factors. And so I think that was the first point. And then the second point being, it would be interesting to know as a comparison to those who were well engaged with technology versus not so well engaged with technology, right? And I think that there was definitely an element of a recruitment bias for this study as a pilot study, that the people that we ended up recruiting to the study were probably more likely to be people who were well engaged with their technology because they had to be on pumps, they had to be on CGMs, and then they also had to have the bandwidth to be uploading with a consistent frequency at home and engaging with the medical team. So I think there definitely is an opportunity to kind of parse that out a little bit further. I will say that we do have future efforts that are actually looking to shift the focus to people who we are really, really hoping with potentially lower engagement, whether they're not on technology yet or are already on technology, but maybe not using it optimally, really focusing on that subset of our population to try to see how this improves engagement for those who are less engaged. So those are really great points. Thank you.
Interest of time, we'll move on to our next speaker. Thank you so much. Bear with me. The next speaker, I'd like to welcome Ashley Garrity from University of Michigan, CS Mott Children's Hospital.
Hi, everybody. So I was also just to give you an update on time. We have a little bit more time than what the agenda says. So, you know, you don't have to run out on me, although feel free if you gotta go. So I'm here to talk about our Diabetes Data and Devices D3 education program, which, as you guys have probably heard in the last plenary session, or maybe in a breakout yesterday, our team put together the 6 habits. And so those are those measures around glucose monitoring and insulin delivery. And this really focuses on what we refer to as habits 5 and 6, which are whether or not patients are looking at their data between visits and whether or not they're making insulin dose adjustments. So this is a nice piggyback on the last presentation, because as it was mentioned, we need to really make sure that patients have the tools and the skills and the knowledge to be able to do that, because, you know, we historically didn't teach people how to look at this data. So I will breeze over this, but this is just a little overview. We are located in Ann Arbor at an academic medical
Ashley,
center.
Can you hear me? This is the sound of Sarah from Zoom. Hello.
Yes, hi, Sarah.
We're still seeing the last presentation, at least the people
no.
actually.
Okay, hang on just a second.
Sorry about that.
No, thank you. Hello.
Hi. I'm just bossy pants, even when I'm far away.
That was my fault. I take full responsibility. Can you see it now?
Yes.
Sorry about that.
Perfect. Presentation.
Luckily, you didn't miss much, because everything I was saying before was just my title slide. So,
no, it's perfect. I want to hear what you have to say. So I wanted to make sure we got the right view. Thanks.
Thank you. So this is just an overview of our site and our team. Just something to point out too, the 2 in bottom for our team with social work and psychology, I put those in italics because we have, like many sites, experienced some turnover. And so we are currently, our psychology spot is vacant, and we are down 50% of our normal social work FTE. So while that doesn't necessarily directly relate to this particular project, it's just something that I think, you know, we can all relate to. So we have about 1,350 established type 1 patients. We have between 100 and 150 nuances here. So, oh, this is very large, this font. So just a background, we all know that our patients are using more technology, CGMs and pump use are, you know, becoming more prolific, but patients still aren't reviewing their data and doing insulin adjustments on their own very often. We know that retrospective review and doing these insulin dose adjustments is associated with better outcomes. So as I mentioned, these are from our 6 habits paper. So I highlighted habits 5 and 6, but it does show that, you know, patients who are performing those habits have reduced A1Cs and higher time in range. And so we wanted to try to provide patients and families with training so that they could interpret their data and make adjustments on their own. So I apologize that the slides are formatted so wonky. So just to overview, I know some of you have heard about our program before, but if you're not familiar, we put together an interdisciplinary team with myself and Dr. Joyce Lee, who's our pediatric endocrinology PI for the T1D exchange, as well as some of our educators and a graphic designer to develop this curriculum. We did a literature review to see if there are any existing guidance or curriculums out there. And then we also did several qualitative interviews with providers, both at our institution and other sites, to see how they walk through this process with their patients. The key things of this curriculum are to help understand key glycemic metrics, in particular time and range, since that's an important metric as far as CGM is concerned, that is fairly new in the world of, you know, goals for glycemic control. Identifying patterns of hypoglycemia and hyperglycemia in their data, and then knowing how to address those with both behavior changes and insulin dose changes. And so we looked at our attendance and pre and post glycemic outcomes, and we also gave a couple of questionnaires to assess self-efficacy and diabetes data literacy, pre and post. So this is just an overview of what we teach in the D3 class. So it covers those same topics. Importantly, we want to make sure that when we're teaching the class that we kind of level set, because some of our patients are fairly newly diagnosed. The only requirement that we have for participating in this education class is that they've attended our basic education. We don't have any rules around how long it's been since they've been diagnosed. So sometimes we get very eager, newer patients, and sometimes we have patients that have been doing this a long time. We recommend that our providers suggest the class and offer it to their patients that might be approaching transition, because it's a good way for patients as individuals and adolescents that they build their skills. So we want to make sure that we're level setting and we cover all of the basics. Many of our kiddos are on pumps, but we go back to the basics of how to calculate doses, just so that everyone is coming at the review and the adjustment pieces from the same place. So this is just an example of one of our slides of how we show both CGM trace views and we show logbook views depending on the composition of our class. We kind of tailor it to who's attending that day. We do teach this class virtually since COVID. And so, you know, we tend to have anywhere from, I would say 3 to 7 families is usually our class size. And so it tends to be very interactive and we tailor it to what devices families are using, but we cover, you know, going over different time periods in their views and then giving them the tools that they need to interpret the data and recognize if they're seeing patterns of highs or lows. So we really stress that with CGM data, you're looking at a 2-week view and that this is kind of giving you that big summative view to help you identify where you're seeing trends. So here's another example. We review our bolus dose calculator just to make sure everybody's kind of approaching this from the same knowledge space. And then we talk about adjusting doses. Our recommendation is that we guide families to make adjustments by increments of 10% because our team feels that that is safe for families to do on their own. So we talk about how to calculate a 10% dose change. And we also give them cheat sheets with adjustments for both long-acting insulin shots, as well as making bolus adjustments for pump. So just to cover our results, so we started teaching this in 2019 and through August 2020, we've had 155 of our patients' families attend a class. For the purposes of the results in the analysis, we excluded some of our new onset patients. So if they were within 3 months of diagnosis, we took them out just because when we want to look at change in A1C, we know that they can be a confounder, that they often have a very high baseline A1C at diagnosis, and we didn't want that to skew our results. So we looked at pre and post attendance in their A1C. So we didn't collect A1C for the purposes of this class. We used their clinical data points. So we took whatever A1C was closest before the class, and then we took their A1C that was at least 365 days after. But they're not all quite the same time window because we were using their clinical data. But we have seen some really positive reductions, an average reduction among our participants of almost 0.5%. And we saw a greater effect for patients who came to the class with an A1C that was greater than or equal to 9%. So our kiddos that had higher A1Cs to start, we saw a greater effect. And similarly, we also saw some variations by age with a greater effect among the littlest kids in the 0 to 5 age group. So these are just some graphs that summarize that same information. But as you can see, in those kiddos that had a starting A1C of 9 or above, we saw over a 1% decrease within a year of participation. And similarly, it was almost a 1% decrease among our youngest kiddos. So in conclusion, we feel like this program has been successful in educating and empowering our patients to look at their data. Qualitatively, I didn't include any of this in here, but we've received a lot of really wonderful feedback from families who, you know, say, I didn't know that I was allowed to do this. I didn't know I was allowed to make adjustments on my own. No one ever told me that I didn't have to call the clinic. And so we think it's really great that we're kind of giving them the tools to say, you live this and do it all the time. So you guys, you know, we're just giving you a little extra confidence and knowledge to help you do what you're already doing. So thank you guys.
I'm wondering from like a longitudinal application, how families are informed that this class exists, or how do you foresee making sure that it's not based on a provider or an educator telling them, oh, this is available, that everyone has equal access to this class?
So the question is, how do our patients and families become aware of this class existing and whether or not, you know, it's only certain people who are promoting the class? So I feel like, have you been sitting in on our local QI meetings? Because this is literally what we've been discussing for our little micro tests of change. But Dr. Lee teaches the class actually, and the goal has always been that it would become a permanent part of our education program, but we've had a lot of staffing changes. And with COVID, we had to switch from teaching it in person to virtual very abruptly. And so that's something that we don't feel like it's fully institutionalized. So we've been working very hard on trying to promote it. So we send out an electronic newsletter to all of our patients every month who are signed up. And it covers, I would say, at least 75% of our families. And so we advertise the dates that the classes are offered in that newsletter, as well as how to sign up. It's also available on our website, which is public and open, umpedsdiabetes.com if you want to check it out. And then we've also been trying to socialize it with our providers, making sure that they are promoting it to families. And so we've tried to highlight some of the places where we think this is really important. As I mentioned, transition tends to be a key place. So we remind our teams that, hey, if you have patients who are, approaching late high school years, might be going off to college, might be moving out of the house, it might be good for them to attend this as a refresher so that they can prepare to take on their own management. But yeah, we're still working on promoting it to make it more widely available. One of the things that we are working on is for our new QI project is we're going to be talking about time and range as a measure and what those goals are for our patients in clinic. So we're putting together some provider talking points so that it can be something that they bring up during the visit when they're already reviewing the data. And then as a plug can say, hey, if you want to learn more about this and how to manage, we have this class available. So, but if anybody has any other ideas of how we might promote it to our patients and families, we welcome the feedback.
One quick question.
Yes.
How long does the class take, and would you be willing to share this with the class and share the class with us?
Yeah. So the question was, how long is the class, and would we be willing to share it? So we teach the class over 2 hours. And I would say, to run through the actual curriculum slides, it takes between an hour and an hour and a half. We usually give a lot of case examples. The data that we present in the class as examples is actually all real patient data that was graciously donated and has been de-identified. So we can show real traces and say, hey, this is what this person's doses were, and these were the adjustments we suggested. So we always leave time at the end to kind of have it be an interactive discussion, go through cases. So we do it over 2 hours, but it's, an hour and a half maybe of the didactic portion and then more interactive. And as far as being willing to share, yes, we're actually working with Children's Mercy in Kansas City to have them adapt the curriculum and roll it out to their patients as a pilot. And so we're hoping that we can come up with a model that makes it easily packageable for other sites, because we do think that this is useful. So, yeah. Great.
So much.
Yep. Yes. Okay. Our next speaker is Dr. Carla Demeterco-Berggren from UC San Diego School of Medicine.
Hi, everyone. And I'm the last one, not going to take too long, so we can move to the next round and you can have a coffee. So it's a pleasure to be here. And I'm Carla Demeterco-Berggren. I'm the PI for T1D exchange for our site. And I'm going to show a little bit of our QI in increasing frequency visits among Medicaid insured children and adolescents with type 1 diabetes. So just a little bit of background. We know that the relationship between more frequent clinic visits and improved A1C levels in people with type 1 diabetes has been reported. And the ADA recommends quarterly follow-up visits for routine diabetes care, but we know that this is not always attained. So our aim statement, it was to increase the percentage of Medicaid insured children and adolescents with type 1 diabetes who attended at least 4 or more clinic visits per year from May 2021, a baseline of 53% to 75% by May 2022. So just to give you a little background in this subset of this population that we did the interventions on. So we use the diabetes clinic dashboard. We've been, what's that? Should have just. Okay. Can I keep
Okay, I'll keep that. Let's go back to that one. I need to go back to the previous slide. Sorry about that. There, perfect. So, so we use this diabetes clinic dashboard within our EHR system that allowed us to identify all the children and adolescents with type 1 that are due for a visit. So they haven't had a visit for over 4 months, and they don't have any scheduled visit in the future. And we focus the intervention it's a subset of so we're 100 kids, and they're a subset of Medicaid insured patients that have an extra layer of resources, which include care navigation services. It was called initially CKC, or Child Kids Care. That was a pilot for Rady Children's Hospital. We no longer have that, but we still have some funding that we use for this specific group of children. And you can see here in this pie graph, just to have an idea of the demographics, the great majority are from minority racial and ethnic backgrounds. So over 50% are Hispanic, 16% African American, and 60% are non-Hispanic white. So we put together a multidisciplinary team, which includes the care navigation team and the diabetes team. And together we developed some identified change concepts, which were tested in a series of PDSA cycles, which I'm going to show you. So here you can see our key driver diagram. And among our primary drivers was ensure access to care and promote health equity. And the change ideas included here, it was the outreach done by the care navigator. So they called each one of those patients that were identified. Provider engagement. So we talked to every single provider, because one of the issues is when we identify the patients, we need to get them right away in clinic. And, you know, we have very busy schedules. So we talked to providers, some of them agree to add them on. And we use that until we're able to add some slots for rescue, we call it the rescue visit slots, to a nurse practitioner schedule. And this is those slots were specifically for patients that need an appointment, that they were, you know, that they need an appointment and that haven't been seeing a provider for over 4 months. Also, we improve multiple workflows, including reviewing the monthly diabetes dashboard reviews. This was initially done by a provider, and this today to provide sustainability, it's done by every single nurse at our clinic. Also, we involve the diabetes nurses to do outreach calls. So sometimes that visit with either the nurse practitioner or the provider, it would take a little bit of time. So the nurse would reach out to that family to review blood sugars, and if necessary, make insulin adjustments and take the chance to look up at refills if necessary, and then do a basic telephone note visit at that time. Yes. Okay. So I think I can do it in 2 minutes. Yeah. No problem. So let me just show. So the interventions include the nurse navigation, our diabetes nurse outreach, the nurse outreach. We create something epic that I can tell you another day. And let's just go to the good part, you know. So from May 2021, we're at 53%. And you can see by May 22, our goal was 75%. We're happy to see that we got to 88%. So continue follow-up with this population is helping us to identify all the barriers that these kids have to get to clinic, and new strategies. You're all there to help us develop new strategies to address these inequities and improve this visit frequency.
And I'll be happy to receive your email with your questions. Let's take a picture.
Thank you so much.